Summit Session 4, our last session. I'm Patty Taylor with the Dallas-Fort Worth Hospital Council Foundation, and I'll be your host for today. We would like to do some housekeeping and thank our platinum sponsor, Methodist Health System, and our other sponsor, Texas Health Resources. We have silver sponsors, Abbott Point of Care, ACHE of North Texas, American Heart Association, and Group 1 Background Screening. Health Catalyst, Interactive Quality, Konica Minolta, and Vitaltech. Thank you to the sponsors for keeping the cost of the program down. We'd like to thank the Patient Safety Summit Planning Committee. These wonderful people volunteered their time to put together the program for us, so thank you very much. We have 10 posters that were submitted and approved. We have them on our web page. Please take a screenshot of our web page right there, because everything you need from the evaluations to the recordings are on this web page. We also have a little contest going. Review the posters and complete a short quiz to be entered to win an autographed copy of the keynote speaker, Megan Johnson, Generation Inc. To be eligible to claim CEs, you have to attend 85% of the session. The evaluation survey will open tomorrow. After our last session has been completed today, we will open it tomorrow. The link, again, take a screenshot, get that link. You must complete your evaluation by October 13th. CE certificates will be emailed to you in 1 to 2 weeks after you've completed the evaluation. Again, all presentations and recordings will be on our web page. As a reminder, you can view the events after, but you cannot claim CEs except for being on the call today. We have quite a few times where you might want to put questions for the speakers. I did a little screenshot here. Sorry, it's a little messy, but I wanted to obviously show you where the red circle and the arrow is on your screen, what you're seeing, to know where to go to ask a question. We also have quite a few chats in this session. Chat feature is not available on this platform, so anytime we ask you to chat and have those little talking icons there, please just type it into the questions. We had no conflict of interest in today's program. So at this time, I would like to turn it over to Teresa Wagner. She is the chair of our Health Literacy Collaborative and responsible for a lot of excellent work with health literacy. So Teresa, I will turn it over to you.
Well, welcome everyone. First, I want to say Happy Health Literacy Month. And if you're not familiar, October is actually Health Literacy Month. So we're super excited that our session is kicking off the month so that you can celebrate along with us. And today's session is the work of our DFW Hospital Council Health Literacy Collaborative that was founded in 2017. And we have done a lot of great work, including some collaborative research together, and it's just been a really great collaboration amongst the member hospitals of DFW Hospital Council. So today, you'll notice that we have packed a lot of speakers into 2 hours. Well, the reason for that is we wanted to show you what all we've done and all the different members and member organizations that participate in the Health Literacy Collaborative. So I am going to just kick it off and start off with our first speaker. So Carol Howe, I'm going to hand it to you.
Thank you. All right. Whoops. Okay, I have control over it. Hi, my name is Carol Howe. I am a professor of nursing at TCU, and I wanted to talk to you a little bit about health literacy and some of the work that we do and some of the members of our collaborative do. So I think historically we always thought about health literacy as a shared, as a responsibility of the patient. It was more about their skills or their lack of skills. But more and more, we think about health literacy as a shared responsibility that we as healthcare providers and health systems, we have an obligation, if you think of it that way, to decrease the demands and the complexities of health for the patients that we see. We recently, in our collaborative, we completed an assessment of the health literate organization in some area North Texas hospitals. And we found that, as many of you probably know in the institutions that you work in, that hospitals are very vigilant with patient safety, with looking at medication errors and how to decrease them. And certainly there's a lot of efforts to decrease 30-day readmissions. But what we found is that these initiatives weren't connected with health literacy, that there were so many opportunities to weave health literacy in, but we did not find that at this time health literacy is not hardwired in. So we have some opportunities where we can do some work. That's what I wanted to talk to you for a minute about. So in terms of health literacy, we know that there have been so many studies that have looked at the impact of low health literacy. We know that there's lots of disparities in health outcomes, that patients have less knowledge, they have poorer self-care behaviors, they have increased complications with their diseases, and also we see increased 30-day readmissions, increased ER visits, and increased medication errors at home. There have been two studies that I know of that have really looked at the cost of health literacy. So one that's quoted often is Vernon's work, where that they estimated that health literacy would cost $106 to $238 billion annually, and that it's expected to rise to up to $3.6 trillion. Recently, another group headed by RASU, they estimated that health literacy costs $215 billion annually. So the estimates are close. The Institute of Medicine in 2010, they put out 10 attributes of the health literate health organization. And these range everywhere from how leadership can promote health literacy, how we can weave in health literacy into plans, into evaluations, into improvement projects, that we have a need to prepare the workforce and train them with health literacy practices. And all that helps to ensure easy access for patients. That's our whole goal. And when we are in touch with patients, that we're communicating effectively. And so that's using things like TeachBack that I'm sure many of you have heard of, or even using your practice daily. And as well, there is a hope that we're explaining coverage and costs in a way that's clear, and that we're targeting our communications during high-risk situations. For example, when moving from an ICU to the floor, or during discharge, whenever there's a transition in care, that we're doing clear communication. And we support our clear communication with easy to use health materials that they're designed thinking about the grade level as well as just how friendly they look for patients, and that we're meeting the needs of all, and we're including consumers as we think about health literacy initiatives, what is their input. So that's a 30-second view of the Institute of Medicine's 10 attributes. But one thing I really wanted to talk about is our opportunities as healthcare providers, as nurses, dietitians, pharmacists, social workers, physical therapists, occupational therapists, child life, all of us that work with patients, that we have an opportunity to be a health literacy champion. And when you look at the literature about champions that take on innovative practice or evidence-based practice, how do they implement it and integrate it into their work? All this, health literacy is one of those. It's evidence-based practice and innovation. So the champions that have been successful, what they have in terms of attributes is that they tend to have influence with their colleagues, influence within the system. They certainly, hopefully, have some confidence, belief, and ownership. And in this case, we're arguing for the belief and ownership around health literacy, why it does good. Of course, being physically present in the unit, on the clinic, so that you can use your influence and ownership of health literacy to start to move the needle on health literacy is important, to be physically present and be part of that team. Oftentimes, champions also risk their personal status because they're pushing for change despite maybe, sometimes it's an uphill to push for change and to sustain change. And that's where grit comes in. And grit is really defined as being persistent despite meeting obstacles. And that then the last is persuasiveness. And being able to persuade your colleagues of why health literacy is so important. So those are what people have talked about in the literature about what makes a champion, and certainly that's how we think about a health literacy champion. So champions, though, looking at health literacy research specifically, the champions have been integral to the success of health literacy. There are several articles out there that talk about champions in hospital systems, in clinics, in large and small systems. And they've often partnered with leadership and certainly have shown that their persistent effort led to systemic adoption of health literacy in their organization. And the bottom line is champions won the hearts and minds of their clinician colleagues, really showing and telling their stories of how health literacy made a difference. So for example, as a champion where I worked, I started using TeachBack and started sharing what I found with my colleagues. So for example, I work with families that live with diabetes, and I had made a change in an insulin to carb ratio and a basal dose for a family, for a mother with her young child. She happened to need to give the insulin dose there in clinic. She hadn't given it yet. And so I said, hey, why don't you just pull up the insulin? And when she did that, I realized that she could not read the numbers on the syringe. So when I changed the dose, she could not pull it up. And without that TeachBack, I would never have known that. And I had been working with this family for years. So I was so surprised to discover this and shared this with my colleagues. And we all started doing more TeachBack and sharing stories of how where we thought we were being so effective, we were missing the mark. And so we were able to change our practice to be more health literate. So in terms of looking at our senior leaders, what can they do for health literacy champions like us? Well, certainly we need our leaders, our nurse managers, our directors, our vice VPs in our organization. We need them to help us to protect your time, to remove barriers, and to make your health literacy efforts and patient impact visible. So they can bring the stories that you find as you do health literacy practice. They can bring them to the boardroom, they can bring them to their donors, and so that you can get more support for your health literacy efforts. Certainly, they help build support for your health literacy efforts everywhere and anywhere. So how do we get, So how do we get our leaders involved? The first thing to do is really to teach them about health literacy. So show them the strength of evidence for health literacy practice. For example, what happens when we do TeachBack regularly? Well, we know that that increases patient knowledge. It increases their self-care. It increases their disease outcomes. And it also reduces, there's also a money, it also helps to really talk about how it saves your institution money. It reduces 30-day readmissions and reduces preventable ER visits. And that's something that's important for leaders to know, that there is that evidence out there. So teaching them about health literacy is certainly a first step. You can also show leaders how health literacy links with the organization's goals. So for example, often institutions are working towards patient-centered care, improving quality and safety, and those are all ways, there's ways that we can weave in health literacy efforts within the goals of the organization. But it's up to us as champions to bring that to the attention of our leaders. The other thing is that when you're involved in health literacy, we really like to walk the talk. So we model plain language when we're speaking and in writing. So I encourage you to become a health literacy champion. This is Health Literacy Month. It's a great time to jump on board. I wanted to show you two resources. Oh, I guess that my slide isn't there. I wanted to have you attend to two different resources that you might be interested in. The Agency for Healthcare Research and Quality has a health literacy toolkit. You can really just type in your search browser, health literacy toolkit, and it'll come right up. Also, the CDC offers a health literacy module that you can get continuing ed credits until July 2022. And so in addition to this, that module may be something that's useful to you. So now I'd like to turn over to talk to our next speaker, Barbara Stephenson. She's from Cook Children's. Barbara.
Thanks, Carol. Before I start, I'd like to take just a little step back and look at where we started with the summit and talk about also the slides Carol showed us of the Institute of Medicine's 10 attributes. And more than half of these attributes relate in some way to providing access or communicating effectively. Listening to our consumers can teach us a great deal about how to become more health literate. This is a quote defining the patient experience from the Barrel Institute, an independent organization dedicated to improving patient experience. Many of you may also be familiar with a Joint Commission publication titled, "What Did the Doctor Say? Improving Health Literacy to Protect Patient Safety." That article stresses the importance of clear communication in every interaction from reception to discharge planning. As previous speakers have shared, the patient experience and patient engagement can be influenced by any number of variables relating to health literacy. These may include, but are not limited to, things like confusing signage, unclear patient education, complicated wording of forms, to even rushed discharge instructions. It is important to remember that patient experience begins and ends with good communication, and health literacy awareness helps shape our messages and our interactions. As Carol just noted, health literacy is a shared responsibility. With patient-centered care, it's critical to make a conscious effort to adjust our communication so that information is accessible to everyone. Given the complexity of our healthcare system, in order to have patients actively participate in their care, providers ideally need to include them, or even their families or caregivers, in the design, implementation, and evaluation of health information and services. A 2016 article entitled, "How Can We Talk About Patient-Centered Care Without Patients at the Table?" provides case-based evidence that patient involvement improves quality and safety in medical care. And a 2018 study published in the Joint Commission Journal on Quality and Patient Safety found that leaders felt patient partnerships positively influence quality improvement, anywhere from a moderate amount to a great deal. Yet even with these findings, how often do we invest in initiatives and programs that are based on meeting benchmarks or reducing costs or reducing risk without any input from our consumers? Last week, many presenters talked about a number of successful programs involving patient and family participation. The improved quality and safety outcomes of these programs were the direct result of these consumer partnerships. Here's what our patients have taught us about face-to-face interactions and some steps organizations can take to elevate the importance of health literacy in everyday communication. Typically, people with low health literacy skills or language barriers respond passively during encounters. Head nodding or lack of questions does not signal understanding. One cannot assess health literacy by just looking at someone. Experts recommend using a universal precautions approach. We should communicate with the assumption that all patients may have difficulty understanding health information at some point. And health literacy can change over the course of interactions based on outside factors like distractions, fear, lack of sleep, or simply just being overwhelmed with information. Patients have distinct learning styles and needs that health literacy needs to address. One size does not fit all. How does the organization identify gaps in communication and education? How prepared are we to meet the needs of a severely dyslexic patient, or a non-English speaker, or perhaps someone who may converse in English, but who may prefer to read in another language? Do consumers feel comfortable asking questions? Are staff rushing from patient to patient, or do they take the time to really listen? And how are we ensuring that patients have adequate understanding to participate in shared decision-making? Is the organization committed to using evidence-based health literacy tools? Are there more formal skills assessment programs like boot camps for patients and caregivers? And are consumers involved in their design? Are they asked to provide evaluations? We've talked in previous sessions about the value of contributions from patient, caregiver, and community member participation on councils and committees. With all the tools organizations use to collect data and gather customer feedback, are we asking the right questions to better measure our performance as it relates to health literacy? Are we consistently providing opportunities to involve consumers in reviewing written communications? Do we ask specific health literacy questions in our surveys? These would be questions like, did you receive any patient education? How clear was the information? During the encounter, did you have an opportunity to ask questions? Were you able to understand the answers? Were you asked to explain information back in your own words? And what more can we learn about health literacy from our physician reviews that ask questions like this? How well did your provider explain information? Did you feel rushed? Did you feel that the clinician listened? Were the discharge notes or the after-visit summaries clear? Oops, sorry. Next slide. What did I do? Sorry, folks.
One moment, please.
Sorry. All right. Okay, I'm sorry, guys. Finally, in addition to what we learned from face-to-face communication and actively soliciting feedback, there's much to learn from patient behaviors. Is it likely that any of these actions or inactions could be, in part, a result of some issue relating to health literacy? How are we communicating with families to better understand what is the cause of these behaviors? As we look at outcomes through a lens of health literacy, we have the opportunity to improve processes and potentially drive lasting improvements to quality and safety, and ultimately to patient satisfaction. Our greater challenge beyond just gathering information and feedback is to take all that we can learn from our consumers and make meaningful use of it on a broad scale, to find ways to create an organizational culture where health literacy is a priority. In closing, I'd like to share this quote from a recent article describing health literacy journeys at 3 different organizations. As organizations' efforts mature, health literacy quality improvement efforts give way to transformation activities. And now I'll hand it back to Teresa.
Thanks, Barbara. So Carol and Barbara have laid a great foundation to get you thinking about some of the things that may be occurring within your organization as a result of health literacy, and how that may not only be costing you in terms of patient outcomes, patient opinions, and the bottom dollar, but you might be sitting there thinking, wow, that's all pretty scary. But where do I start? How do I make that happen within my organization? So to give you kind of a roadmap, I'd like to review with you, and many of you are probably familiar with, the 8 Steps of Change by John Kotter. And the reason that this really resonates with me is I did my doctoral residency in Austin in health literacy. And as a part of that, I worked with a lot of healthcare organizations, both state-funded and private hospitals and public hospitals. And I did a lot of health literacy work with those hospitals. And many of the privately funded ones spent a lot of money, and publicly funded ones, to have me come in and do health literacy training with them. And the sad part for me was when the economy changed, they eliminated health literacy positions, and all of the work that I had done with their organization disappeared. So Carol and I just wrote a grant and really want to focus and bring home to you how to make health literacy efforts sustainable. within your organization. And in order to do that, you have to create a new culture of health literacy. So how do you start? Well, create a sense of urgency. You've heard some stories already today, and you will hear some more throughout our session about the impact of health literacy on people, on your organization. So you need to sell the need for change, tell health literacy stories, immerse people in information about health literacy. So some of your employees might not even know that it's an issue, like Carol demonstrated, that it wasn't until she did that anecdotal teach back that it brought it home to her, and then she was able to share it with her colleagues. Discuss ways to solve the problems. People identify with the change, so that people will identify with the change, and empower people to solve the problem. Give them the tools that they need to be able, the time to do teach back, the time to distribute teaching throughout the hospital stay instead of doing it all at the end. And then you can always use data. You can use stories of people that have been hurt or harmed by these lack of communication or poor communication. So in 1995 through 2005, ineffective communication was identified as the root cause for nearly 66% of all Sentinel events. That's a scary statistic. From 2010 to 2012, ineffective communication was among the top 13 root causes of Sentinel events reported. So you can use data, you can tell stories about patients, but create that urgency. And then you need to pull together a guiding team. And that same grant that Carol and I just wrote, it's for helping to promote health literacy in primary care clinics. But what we realized in writing the grant and doing our review of literature is that it really takes not only an external facilitator, which we would be as the health literacy experts, but also internal facilitators. And that means bringing together this team of strong leaders that would help to drive this change within your organization. And it needs to be multidisciplinary. Your leadership in that team needs to have high credibility and integrity, strong positions of power and broad expertise, and then have both management and leadership skills on that team in order to drive that change. So one thing that we know from working in health literacy and obviously in the organizations that I worked with where health literacy went away as soon as they let go of that position, is that we need leadership buy-in. And Carol talked a little bit about that in terms of that's the key to making sure that health literacy stays within your organization, because it has to be a culture of health literacy that is brought home by this team of experts that are going to be championing it within your organization. The other key is including it in your mission, vision, and values. And in the study that Carol, myself, Tracy, who you'll hear later, and Brennan, who you'll hear later, did last year, which will be published this December in the American Journal of Nursing, what we found was that health literacy was not included in anyone's mission, vision, or values. Although they might have statements somewhere that alluded to it, it wasn't strong enough to drive health literacy. And then the other part is that it needs to be in the strategic plan in order to establish accountability for making sure that health literacy is present. So standards for effective communication, if you've done team steps before, you know that communication is key among team members, and that, and these are all also health literacy tenets in terms of making sure that the communication is complete and provides all relevant information, that it's clear so that everybody understands, that it's brief because we need to get on with our jobs and do them efficiently and effectively within the hospital and primary care setting, that it's timely, that it is in an appropriate time frame and not after the fact, And then verify the authenticity. So making sure that it is factual and that it's validated through Teachback or other health literacy tools. I know my dad was in the hospital last year and had quite a difficult recovery. He went in for what should have been a simple procedure, and it really ended up badly. But in the meantime, my mom was not used to advocating in healthcare, and so I had to go down to Austin to help her. And it was much to my dismay that twice while I was there, I was asking about medication from one of his nurses at that time. And she told me she didn't know what medications he was on because she hadn't been told in report. Now you can imagine me working in patient safety and her giving me that answer and what my response internally was. It was very upsetting. And then the second time I had a nurse, not necessarily around medication, but tell me that she had not received report and wasn't familiar with my dad, although she was caring for him. So communication needs to take place, and we need to communicate for understanding and buy-in. So stories such as that, you know, encouraging discussion, and if people are resistant to change, then meet that head on and listen to them about why they're resistant, empower them in the ways that they are resistant so that they aren't afraid, they aren't trying to cling to the way that things have always been. And then find role models that are doing the right thing, like Carol doing Teachback, using plain language, chunk and check. So offering a little bit of education at a time, and then making sure that the patient has retained that through doing another education session later in that same hospital stay, or if you're in a primary care, each time they come in, making sure that they're still understanding their self-care. And then value resistors, because sometimes we think we know what's best, and that's why we have this team, is so that we get perspectives from all over the healthcare system in which we work that can help us understand why something may or may not work based on their perspective. So, you know, their tough questions can actually strengthen the change, and they may actually have a better solution. And by letting them voice that and engaging them, you might find that you have better sustainability. So not only may we have resistors, but we also do have communication challenges, and we're all familiar with these things. And actually, having studied for the patient safety certification exam, I can tell you that many of these were on there. But language barriers, distractions, physical proximity, like now, we're all working from home, or many of us are. So just having to do this communication remotely is very challenging. Personalities, you know, we may not read somebody right because everyone has a different personality. I know that you might not think this, but I tend to be very introverted. So it's sometimes difficult for people to read what I'm thinking. Workload, we know that our staff and our professionals are very overworked and very overburdened. So how do we help alleviate that with and empower them to make these changes? Varying communication styles, conflict, lack of information verification, and shift change, which we just talked about that. So all of these things can be barriers to communication, and we make assumptions, we may be fatigued, we have distractions, and then there's the HIPAA regulations that might keep us from communicating fully when we can't. So empowering others to act, providing them direction and giving them, you know, these team-driven solutions, encouraging others to speak up and take risks within the new paradigm, and share what you know about health literacy and how it can be better incorporated into your day-to-day practices. Encourage teamwork and collaboration. I both not only took the patient safety exam, but also just went through team steps, and all of that foundational knowledge can only do improve how people work together. So I encourage you to educate and empower all of your professionals and staff. And then encourage personal reflection and learning. And like I said, they will feel more confident with this training and being invested in health literacy and setting short-term goals so that they can feel successful. So quickly, here's a communication challenge scenario of an 89-year-old female with a history of diabetes, instructed on medication as she was being discharged, but she can't read well and didn't understand the insulin dosages, very much to the story that Carol told you, except on the other end of the spectrum. She's sent home without her medication in hand and has no way to get it. And her family didn't realize that for a couple of days. So just in your head quickly, or if you want to jot down on a piece of paper, where does miscommunication occur in this situation? And what actually might happen to this patient as a result? And I'm just going to give you a quick second to think about that. So what we want to do to keep that from happening is to change the culture. So what could have happened is where the miscommunication happened was that the patient was instructed at discharge, her family wasn't involved in the instruction. These are all health literacy tenets. Teachback wasn't used to find all of these errors that were occurring in the communication that we thought was being transferred. So the outcomes was that at home, she either became hyperglycemic or hypoglycemic and then had an adverse outcome and potentially got readmitted to the hospital, if not something worse. So to change the culture, we could avoid miscommunication by having instruction conducted throughout the hospital stay, which I've alluded to several times, or have it ongoing with her PCP. Family should be involved in her care, and Teachback and other health literacy tools should be used. So again, producing those short wins, telling those successful stories, positive feedback to your staff when you see them doing well with health literacy, using Teachback, and providing that leadership with the evidence of these successes can only build momentum and help draw in these neutral or reluctant supporters. And don't let up. Continue to acknowledge hard work, reaffirm, celebrate successes, bring people together by including it in the mission, vision, and values, and also in the strategic goals and plans with this health literacy vision. And then create systems and structures that reinforce and reward the new behaviors. And only through that can you create a sustainable culture of health literacy. So signs, emails, campaigns, competitions, rewards, involving patients, and Barbara spoke to this quite a bit, and taking that patient feedback and acting on it. That's where we drop the ball a lot, is by not acting on the patient communication. And by doing all of those things, you can create a new culture and develop performance measures. That's one tip that is widely recommended, because only when it's part of performance measures and not punitive, maybe in a coaching way, that people will actually adopt those behaviors and make them a part of their normal practice. So one thing I do know is that people say, tend to say, well, we're changing the culture. Tomorrow, we're going to be a health literate organization. But what we've learned, as you've seen as we've gone through the slides, is that the culture change actually happens at the end, because you have to lay down all of this infrastructure and all of this time and planning and including in the mission, vision, values, and strategic plan in order to make that the new culture. And of course, again, emphasizing leadership has to be on board to make that happen. Otherwise, you'll just go back to the old culture. Here's the resources that Carol alluded to earlier, if you want to take a screenshot of that. These were the resources that we used. I also pulled, she mentioned the Universal Precautions Toolkit. I also pulled Team Steps material from AHRQ as a part of my presentation. And I'm going to pass it off now to Amy Sixmeans and Amber Richardson.
Good morning. This is Amber Richardson. I'm an occupational therapist at Medical City Alliance, and I have the privilege of, kind of being boots on the ground, providing daily patient education. During our presentation, there's a lot of participation opportunities, so I hope you can take a second and find the questions section. At first, I just want to take a few minutes to brainstorm words that you think about, words, phrases that you associate with patient education. So go ahead and fill that in. And Patty will be helping monitor the questions.
So we have teach back. Please type your question or your answers into the questions. After visit summary. Clear and simple. Too much information at one time. Teach back, chunk and check. No medical jargon. Start early. Easy to read. 5th grade reading level.
All of these.
Eliminate clutter in documents.
I love all of these. These are great. So be thinking about these things that you associate with patient education, and I hope that by the end of our segment, you'll have a deeper understanding of what health literacy informed patient education looks like in real practice, and also how it relates to patient confidence, patient engagement, and patient satisfaction.
Hi, this is Amy Sixmeans, and I am with Children's Health, and Amber and I are going to be presenting to you a set of videos that we created to show the difference between providing patient education that is pre-health literacy training and then patient education that is informed by health literacy understanding and training. And Carol and Barb in particular spoke a lot about Teach Back and how patient education and Teach Back helps to reduce the possibility of hospital admissions. But they also spoke about how it also just impacts patient safety as well. And so we actually are going to speak to that in our videos. We hope you enjoy watching these videos as much as Amber and I did making these videos. So off we go.
Good morning. Please state your name and date of birth.
I'm sorry, what?
Please state your name and date of birth.
Amy Littler, 4/18/70.
Okay, my name is Amber. I'm the hospital ostomy specialist. I have a lot of very important information for you today about how to manage your ostomy. Why are you not giving me your full attention?
I'm sorry, but you just woke me up and I'm still not feeling really good after the surgery. And there's so much to take in. I don't know how I'm going to deal with this.
Well, living with an ileostomy is just something that you'll have to get used to. There are a million people living with ostomies, and you're going to need to learn how to manage it by yourself at home. You're currently wearing a Hollister two-piece cut-to-fit pouching system. It's a flat system. Any questions?
No.
And then you'll need to empty it as soon as it's leaking or 2 times per week. Always check the faceplate or wafer for effluent. If it's leaking, change it immediately to protect the skin. Measure the stoma opening 1 millimeter larger than the stoma. Remove the pouching system with good skin protection techniques to protect the stratum corneum. Warm the faceplate to activate the tachyphyres. Clean the skin with water only. Apply barrier spray and apply your new pouching system. Any questions?
No.
Okay, will you teach back to me exactly what I just said?
I need to change the pouch once a week, and when I do it, I need to clean the skin around it with, soap and water.
No, that's not exactly what I said. I brought you information. You're going to need to read it so that you understand. I'm glad you don't have any questions. Have a good day.
Okay.
Okay, so that was an example of education that was not informed by health literacy, and I'm hoping that you'll have a whole bunch of ideas of what you would do differently in this education. Unfortunately, this is the way that a lot of education is given, so if you could type in the question box specifically what you would do differently before we show the following 2 videos, that would be great.
Well, we got that was horrible, and not your acting. Your acting was good. And we do know there were some issues with the audio on that one. Hands-on demonstration, no eye contact. Ask the patient if it's good, demonstration and hands-on. No medical. Teaching material with pictures. Good comments.
Those are great comments. Any
Talk
others?
too fast. Schedule a time to meet. That's about it.
Great. I'll turn the time over to Amy.
Next slide, please. It's not moving forward for me, Patty.
No problem.
So we have a survey for you that we would like you to just take a couple of seconds to look at the question and then respond to the survey. And Patty, can you pull that up?
Yes, sorry.
Okay, so you can see here the survey question is, how confident do you think this patient is going home? And if you could just click on the response that you feel provides a confidence level, and then we'll see the results in a couple seconds.
The results are coming in nicely. We'll give you 10 more seconds to answer. And I'm going to go ahead and close that poll and share the results with you.
All right. All right, for the next 2 videos, I think we've already had this question and you guys have answered it really well. The next 2 videos, in the handout section, you will note that there is one handout called the Teach Back Observation Tool. And we would like you to pull that up and have that side by side, if you can, while you're viewing the next 2 videos, so that you can see how many of those tools within the Teach Back Observation Tool are actually, the checklist, are actually being used during patient education. So these 2 videos are a little longer than the last one, but again, we do hope you enjoy it.
knock, Miss Irving.
Hey.
May I come in?
Yeah, sure.
Hi, my name's Amber. I'm here to support you through your upcoming ostomy surgery.
Okay.
First of all, what would you like me to call you?
Oh, you can call me Amy.
Well, Amy, it's nice to meet you. I brought some information to share with you, but more importantly, I'd like to hear a little bit more about you. Could you tell me a little bit about who you live with and what a typical day looks like?
Well, I live with my son. He lives with me part-time while he's going to school, and I teach, so, most of the year I'm at school all day. Sometimes I go to other schools, I travel to other schools to see programs they're doing, and then in the summer I get to travel, which is one of my things I love to do most.
Oh, that's great. What do you do for fun?
I garden. And my favorite exercise in the world is swimming. So whenever I can get a chance to swim, I swim. I'm at the local Y.
That's wonderful.
Yeah.
That's great exercise. Well, as you've been thinking about your upcoming surgery, have you had any concerns, or what have you been thinking about as far as getting back to your regular activities like teaching or swimming?
Well, I don't see how I can swim once I've got this pouch thing, and I'm not really, traveling with it and being in groups and having to stand up in front of my kids. I feel uncomfortable with this pouch. I know it has to be done, but I'm like, what are people going to say about it? And how am I going to answer questions? And I know they're going to ask questions that are going to make me uncomfortable, so.
Right. These are all really valid concerns, and I have good news. There are actually 1 million people living with ostomies. They're probably walking around and you have no idea that they have ostomies. So you can choose who to tell in your life that will be supportive and who not to tell. But if it would be helpful, I'll set you up with an ambassador who has firsthand experience of what it's like to live with an ostomy that could meet with you after your surgery.
I think that would be great. I've been doing some reading on it. I've looked at some blogs, but I don't know what questions I'm going to have and what's going to happen after the surgery that I'm like, so having somebody to talk to who's gone through it will be really helpful.
That's great. Yeah, having firsthand experience is a great thing. I also have good news for you. You can absolutely swim with an ostomy, and I encourage it. Any kind of exercise is good for you.
Okay.
Okay, so there's even a company that makes special clothing for people with ostomies. They make special underwear or wraps, and I brought a swimsuit
Really?
to show you. Yeah, really.
Oh, I didn't find any of that in my internet searching.
So this is a sample swimsuit bottom, and inside there's a pocket.
Oh, where the pouch would go.
Exactly.
Oh, so nobody would actually have to see it.
Right, it gives you a little bit more support and security when you're swimming.
Okay.
So you don't have to buy special clothing, but if you want to go on a shopping spree, I'm including a 50% off coupon in your starter kit
Okay.
to buy clothing to get you back to your...
Thank you.
Sure thing. So as soon as your surgeon says your incision is ready for swimming, your ostomy is ready for swimming.
All right.
Okay.
Okay.
Is it all right if we talk a little bit about your digestive system?
Yeah, sure.
Okay. So I brought my apron.
Oh, how cool is that?
This is my high-tech medical equipment here. Okay, so this kind of shows what the digestive system looks like on the inside.
Okay.
When you eat food, it goes down the esophagus, into the stomach.
Wait a minute, your stomach's all the way up there?
It sure is.
Okay. All right.
Then into your small intestine. And this is where all of your food and nutrition are absorbed. Even after your surgery, you will have your small intestine intact. So
Okay.
all your food will be absorbed as normal.
So what does your stomach do?
Well, your stomach breaks the food into smaller pieces and adds
so it
acid.
can go through that. Okay, gotcha.
Exactly.
Okay, gotcha.
You've got it. So right now, after the food passes through the small intestine, it will go through the large intestine, which is what absorbs most of your water. And then waste is excreted when you go to the bathroom.
Okay.
Okay? So after your ileostomy surgery,
My what?
your ileostomy surgery,
But my doctor said I was having a stoma.
Right, right. So ostomies are made from different things. This last part of your intestine is called your ileum, and that is what is going to be used to make your stoma.
Okay, I got one more question before you close that.
Yeah.
My doctor didn't ever say anything about my intestines. He said he was going to do an operation on my colon.
Oh,
so where's that?
Good question. Good question. The large intestine is another name for colon. So he'll be removing part of this.
All right. Yeah,
yes.
he just said my colon.
Right. So this part of the small intestine will be intact, and he'll remove part of your colon or large intestine.
Gotcha.
So he'll take the end of the small intestine or ileum, bring it in through the skin, make a stoma out of your intestine. So the stoma that you see outside your body is made from your intestine or ileum. There aren't any pain sensors in it. And then he will sew the stoma here.
Going to stick out here.
Exactly. It will be in the bottom right side of your stomach.
Okay.
Okay? So everything you eat or drink will come out through your stoma into your pouch.
Okay.
Okay. Now, if you think about it, normally your large intestine is what absorbs water, and your food and water won't be going through the large intestine anymore. So what does that mean for you as far as how much water you're going to need to drink?
Well, if it's not going through, if it doesn't go through my large intestine, like, shouldn't I be drinking less?
Well, since your large intestine absorbs water, you're actually going to need to drink more. Your small intestine can absorb some.
Oh, okay. So that's the only way I'm going to get water anymore.
Exactly, is if you drink more.
Okay.
Okay.
All right.
So drinking water will be really important for you to stay hydrated and healthy.
Well, that's not going to be that hard. My kids are used to seeing me walk around with this thing. I already think I'm a camel because of how much I drink during the day. They won't think anything of me drinking more.
Perfect, perfect. That will help you keep healthy. What questions do you have about your digestive system?
Well, I guess none. That looks pretty straightforward. Goes, down, and I just won't have my large intestine anymore.
Great. I love that you're asking questions through our conversation. I want you to keep asking me questions as we go. Some people have questions about skincare or about using a public restroom or about intimacy, and I can be a resource person for you for any of those types of things.
Well, how will I know when I need to go to the bathroom?
That's a great question. You'll know that you need to go to the bathroom when your pouch is 1/3 to 1/2 full. What looks like 1/3 to 1/2?
Well, I guess somewhere like right around there, there's words there, and then there's this dark sort of thing, and somewhere in between the two of them.
That's absolutely right. Just a little above the words is when you would want to empty your pouch.
Okay.
And emptying it on time is going to help you prevent leaks.
Okay.
I'm also going to show you how to empty it. You'll sit on the toilet and open the bottom of the pouch with the Velcro, unroll it, squeeze to open the fish mouth into the toilet. Then you'll wipe the inside of the fish mouth 3 times. This will prevent odors. If there's an odor, it's usually because it hasn't been wiped properly.
Okay, what do I wipe it with?
Toilet paper or wipes are fine.
Oh, just like I would normally do.
Just like you would normally do.
Okay.
After it's empty, you'll roll it back up and close with Velcro.
Well, that seems easy.
Okay, great. So could you pretend for a second that I'm a new ostomy patient and you were teaching me when and how to empty the pouch?
Oh, okay. All right, so this is the ostomy bag, and it needs to be changed whenever it gets about 1/3 or halfway full, which would be somewhere around here. There's letters there, there's words there to help you figure out where it is. And when it needs to be changed, you just go into the bathroom, you undo it, you open the fish mouth, you empty it out, you grab some toilet paper, you clean it out real good, and then you fold it back up, close it up, and you're good.
Perfect. That was exactly right.
Okay.
All right. Well, I will see you again after your ostomy surgery, and we'll keep working together.
All right. I thank you. I feel much less nervous about it now.
I'm so happy. Thank you, Amy.
Okay. See you then.
Right, so as you were watching that film, how does the use of visual aids add to teaching along with printed information and plain language? Can you answer in the question box, please?
It enhances learning. I love the teaching aid. Visual aids understanding easier, adds clarity, thorough. It helped her understand and think of questions. Wonderful impact. It makes everything more clear. Combined methods for visual learners. As a non-clinician, this was perfect. The apron was awesome. Can relate when you see it. The visual aids were very good. Reinforce concrete concepts. Very clear, excellent teach back. Include the why was good. And it makes it more accessible. Great comments.
I love the comments. These are fantastic comments. You can really see how this adds to a deeper level of learning for the patient. And I do have to give a shout out to my rehab manager, Nina Alford, and my CFO, Anthony Villigren, for approving the expense for this apron. I've used it with so many patients. It's not a typical hospital expense, but these are the sorts of things that can be a big difference for someone who has a limited understanding of anatomy, or whose second language is English, or has health literacy needs. And really, all patients have health literacy needs. What examples of plain language did you notice?
Fish mouth. Intestines versus colon.
Good.
Go to the bathroom.
Great. I tried to talk in language that would be accessible to anyone and translate words that maybe they heard from other sources into a way that they could understand. And then also, as you're thinking about this, there's a great example of teach back there. How did the teach back used in this scenario increase the patient's confidence?
Learn one, do one, teach one. She was in control, significantly and more comfortable. Show and tell. Visual understanding of the process. Helps her to say it out loud. Was able to form her questions. Patient got positive feedback, and it made her look confident and comfortable with what was going to happen. Able to touch and feel the actual bag to get comfortable with it. Instant feedback. Provided clarification. Maybe have a roll of TP there also. That's
good
a precious
idea. Good
commodity
suggestion.
right now.
It's a precious commodity. I really appreciate this active feedback. That's great. I do think it increases patients' confidence to actually practice. And notice that when I was using TeachBack, I wasn't testing her skills. I was testing my own education. Did I provide the education in a way that was meaningful for the patient? I was testing how well I did that, not testing her. And yes, it does build her confidence when it comes time for her to actually operate her own pouching system. All right, I think we're ready for the second section of this video. Good morning, Amy. May I come in?
Yeah.
It's Amber.
Amber? Oh, hey, Amber.
Hey, how are you feeling?
Oh, actually a lot better this morning.
Oh, good. I'm going to plug in this IV so it stops beeping and shut the door.
All right.
I checked on you this morning. Your nurse said you had had kind of a hard night.
Yeah, we had a hard time figuring out my meds.
She said she was on her way to get you something more for pain.
Yeah.
I thought I would check back at a better time. How is your pain now?
Oh, much better. Much better.
So happy.
Nothing like having the right pain meds.
That's great. Well, do you feel up to talking a little more about your ostomy?
Yeah.
We can practice some more skills.
Yep.
Do you feel up to sitting up?
Oh, yeah, I think so. I had to get up a few times anyway last night to go to the bathroom.
How is emptying your pouch going?
Oh, it's going okay. The nurse did it for me the first couple of times, and then I did it by myself the third time. I think I did okay.
That's great. You did it yourself?
Yeah.
Good. The more you practice, the more comfortable it will be. So I'm glad you've already done it once by yourself.
Yeah, well, I'm really glad you showed me how to do it and had me practice it beforehand.
It's easier on a practice model, yeah?
Yeah.
I know you said you travel sometimes, so I brought you a card that you can keep in your wallet. It explains to TSA about your conditions. It gives questions they can ask and things they can't ask.
Oh, okay, great. This was one of the things I was worried about.
Great.
Thank you.
And also be sure to keep all of your ostomy supplies in your carry-on luggage so that it doesn't get lost.
Yeah, okay.
Okay. Another thing I'd like to talk to you about is changing your pouching system. Can we talk about a few more skills?
Sure.
Okay. Every time you go into the bathroom, I want you to check the wafer for leaking. You'll see it as either brown or green under this part next to your skin. You would change it immediately if you saw a leak. One of the important things about pouching is that you cut the hole in the wafer just barely bigger than the stoma, not touching the stoma, but right next to it. That way waste doesn't get on your skin. So if you were to pick the right size circle for this stoma, what would you pick?
This one?
Oh, that's really close. I think I might pick one just a little closer to the stoma to protect the skin.
Oh, okay. How about this one? It kind of, just barely goes over it though. Is that okay?
That's exactly the one that I would pick.
Okay.
Okay.
All right.
So we'll work together on pouching your ostomy. I'll talk you through the steps and then I will do it, but I'm going to have you talk me through it. Okay?
All right.
The second time I want you to do it just with me standing by for support.
Okay.
All right.
Okay, so as you can see, we chunked the information pre and post surgery. How do you think patient pain could affect patient education? Go ahead and answer in the question box.
Okay, distracted, not ready to learn. Second in service and written materials. Could make it difficult for the patient to concentrate, lose focus.
Absolutely. So we have to consider the, yes. Are there more?
Not right now.
Okay, perfect. We have to consider the environment that we're giving the education in, and so context is important. The noise can be a distraction. Pain is kind of an internal context that can be a distractor when we're giving education. And why do you think that I repeated some of the information used in pre-surgery here again?
Reinforcement.
Right. So even under ideal circumstances, patients absorb about 50% of what we give them. And so repeating information another time is really important. I'm going to have Amy give a couple more survey questions.
So for this one, you'll notice that we would like you to check all that apply. And I'm sure you will have noticed more than just these 4 options. So if you would like to, you can also click on the other. But what really stuck out to you as patient education that takes limited health literacy into account while you were watching these?
Great, the answers are coming in. We'll have it open for about another 10 seconds to vote. And I'm going to close the poll.
Okay. Yeah, those are actually all that were options in your checklist that you could have checked off while you were watching these videos. And there were obviously more, and some of you noted that by also including other. We do hope you enjoyed these. We have one final, very, very short video that we would like to offer you. And then afterwards, we will, I would like to introduce Brennan, who is also with Children's, who will go next.
A common misconception is that in order to provide education to persons with health literacy needs, the provider needs to provide less information or oversimplify the information. In truth, the provider needs to have a deeper understanding of the material and provide robust education that connects to the client's needs and values.
When providing patient education, it is essential that providers recognize the contribution of patients as at least equally important as their own. While providers are expert in areas like ostomies, patients are experts in themselves. And it is this collaboration between providers and patients that facilitates quality patient education.
All right, well, thank you for your time. And we're going to turn it over to Brennan and her colleagues now.
Thank you so much, Amber and Amy. That was really great. And I think what our section really will continue that dialogue moving forward. You can advance the slide. Next slide, please. Our presentation objectives are really to provide an overview of patient engagement. We'll share some best practice patient engagement tools and strategies to implement at your healthcare organization and really connect the dots between patient engagement and health literacy. So patient engagement is the promotion of patients and families as active members of the healthcare team. And it's the inclusion of patients and families as collaborative partners with providers and provider organizations. And the two really phrases there that stand out are active members and collaborative partners. We know from the literature that patient engagement leads to measurable improvements in safety and quality, improved patient outcomes, and higher patient satisfaction scores. These are all outcomes that we strive for in our respective organizations, yet often the very thing we tend to do is leave out the patient and their family members to get there. We work on fixing or creating new processes to drive patient outcomes without including the role of the patient and their family as key members of the healthcare team. So patient engagement really is key in providing patient family-centered care. And one of the components that we felt was really important to share were the 4 core concepts of patient family-centered care. These are from the Institute for Patient Family-Centered Care. So they are dignity and respect, which means listening to and honoring patient and family ideas and choices, using patient and family knowledge, values, beliefs, and cultural backgrounds to improve care planning and the delivery of care. Information sharing, which means communicating and sharing complete and unbiased information with patients and families in useful ways. Patient and families receive timely and complete, accurate details so that they can take part in their care and decision making. And as you saw in the prior section, really that information sharing shared in a way that's easily understood by patients and families so that they can act and be a part of their care. Involvement is the 3rd core concept, and that means encouraging and supporting patients and families in care and decision making at the level they choose. I often see this in talking with new nursing residents that are new to their practice, and they'll bring this comment to me when we have this discussion, and they'll talk through, you know, there are some families that don't want to participate, and there are some that want to be really involved. And so we really talk through those key concepts because it really is at the level they choose, but it really is our job to provide the information and engage them, invite them in as partners in care. And the last one is collaboration, which means inviting patients and family members to work together with healthcare staff to develop and evaluate policies and programs. You know, really, after hearing about patient engagement and how it is key in patient family-centered care, you begin to see how health literacy is also key. You know, we often talk about patient engagement and we talk about patient family-centered care. However, you may not hear in your organization the term health literacy, but it really is fundamental in the care that we're delivering. And so patient family-centered care, when it's provided, it leads to shared decision-making, and it is really what activates and engages our patient family members. So I'd like to share a real-life case study, and as I ask you, as you're listening, to pinpoint any areas of opportunities that you see in this particular case study, and we'll chat about those later. So this is a 60-year-old male admitted to the intensive care unit after cardiac arrest. He had CPR for a prolonged period of time before his pulse returned. His family had been up all night waiting in 2 different ERs after requiring a care flight trip to a higher level of care. In the second ED, the family was met with a healthcare team member who never introduced themselves before using medical terms to describe his condition, and then began asking the family about withdrawal of care. This conversation took place all before the family even had a chance to see their loved one. After the transfer to the ICU from the ED, the family waited hours in the waiting room with no updates from the ICU team. They continued to worry and wonder. By this point, they were tired. They were going on no sleep. They had no food for hours. And most importantly, they were scared. After multiple requests for an update, the family was updated with the plan of care. However, the plan of care was different than what was shared from the ED. The family was very confused. Over time, updates were always kept brief, but there was little time to process what was shared and very little time for questions to be asked. Hours turned into days in the ICU, and the family noticed variations on how the healthcare team engaged with them. Sometimes the nurses were in the room discussing the patient during shift change. However, their backs were turned away from the family. Other times it seemed that there was no shift change, or at least it didn't happen in the presence of the family. Some staff introduced the oncoming care team member. Some staff updated the whiteboard, but most of the time it was outdated except for team member names. Some staff shared one update while another shared something slightly different. The healthcare team was great at working to save him, but they didn't know much about him outside of his cardiac arrest. They didn't know any details about the moments prior to his arrest. They didn't know what health issues he had been battling months leading up to this event. They didn't have the details of his plan of care. They were only focused on the acute episode. Could it have changed his trajectory? The family may never know. As we move forward, we will revisit this case study throughout our presentation. At this time, I will introduce my colleague Jill Johnson from Scottish Rite for Children.
Thank you, Brennan. Next slide, please. As you've heard during the introduction, it is advisable to use health literacy universal precautions because limited health literacy is very common and can be difficult to recognize. Regardless of background, everyone can benefit from the use of health literacy universal precautions. I want to draw your attention to an important resource that is available online and without charge. Both Carol and Teresa have already mentioned this resource. The Agency for Healthcare Research and Quality has developed a health literacy universal precautions toolkit. Although originally developed to offer guidance and strategies for providers in primary care settings, the tools presented can be a benefit across healthcare settings and disciplines. The toolkit, which is available via the link in our citations, offers 21 tools addressing 4 domains important for promoting health literacy. The 4 domains are spoken communication, written communication, self-management and empowerment, and supportive systems. Today, we will focus on spoken communication and look more closely at tool number 4, communicate clearly. Next slide, please. Clear oral communication can lead to better understanding of health information, positively influencing a patient's ability to understand and follow through on their prescribed treatment plan. The following key strategies can be reviewed with staff, for example, in staff meetings or through emails highlighting a specific strategy, and displayed in non-patient areas, such as breaker conference rooms, or posted in your telephones to serve as a reminder during calls. In today's climate, with increased use of telehealth, these strategies could be posted as a reminder just outside of the camera's view. We'll go through these key communication strategies briefly. First, greet patients warmly. Commit to greeting each patient with a warm smile and friendly demeanor. Make eye contact. As appropriate, maintain eye contact throughout in-person interactions while remaining sensitive to the patient's cultural mores and customs. The ARC Universal Precautions Toolkit also includes tool number 10, which is Consider Culture, Customs, and Beliefs. That includes additional resources. Listen carefully. Attempt to listen without interruption, respond to questions raised by the patient, and address areas of concern the patient shares. Use plain, non-medical language. Whenever possible, avoid the use of complex medical jargon that might be unfamiliar to the patient. As appropriate, use simple, common words that would be used outside of a medical setting. Use the patient's words. Listen closely to the patient's description of symptoms or their condition. When appropriate, use the same words used by the patient when responding. Slow down. Make every effort to speak clearly and slowly at a pace that allows the patient to take notes if desired. Limit and repeat content. Highlight the most important information you want the patient to remember from the interaction. Repeat these key steps or key points for understanding. Be specific and concrete. Try to use clear, unambiguous wording that is not easily misinterpreted. Show graphics. If beneficial for increasing understanding, use pictures, models, or illustrations. Try to make sure that the illustrations are simple and only focus on necessary material. For example, avoid detailed anatomical drawings that include systems that are not pertinent to the conversation. Demonstrate how it's done. A demonstration can be easier to understand than a verbal description. You saw a wonderful example by Amber and Amy that highlights the use of demonstration in patient education. Invite patient participation. Encourage patients to engage, to ask questions, to respond, and interact throughout the exchange. Which brings us to encourage questions. The toolkit also includes tool number 14, Encourage Questions, offering additional guidance on encouraging patients to ask questions throughout appointments and interactions. And finally, apply Teach Back. Teach Back involves confirming a patient's understanding by having them teach back important information that was presented. The ARC Health Literacy Universal Precautions Toolkit includes tool number 5, Use the Teach Back method, for more guidance on implementing this important method. Next slide, please. The following 3 slides show checklists that are part of tool number 4, Communicate Clearly. You should have received a copy of these prior to today's presentation as reference. They're also available in the handouts. Before implementing tool number 4, Communicate Clearly, have staff complete the communication self-assessment following a few patient encounters. You can have staff complete the self-assessment at regular intervals to note changes. Next slide, please. Before and after implementing tool 4, Communicate Clearly, have a trusted staff member complete observations of staff and patient interactions using the communication observation form. Again, repeat these observations at regular intervals to note changes. Next slide. Before implementing tool number 4, Communicate Clearly, consider asking patients to complete the brief feedback form. Administer at regular intervals to note improvements with implementation. Next slide, please. Use the communication observation form while observing the following ARC bedside shift report video. Note the staff usage of many of the communication strategies we discussed. After the video, we'll turn it back over to Brennan Lewis to discuss the case study.
Hi, Joe. We're going to be starting bedside shift report soon. Who would you like to be present?
I would like my wife, Vicki, to be present.
Great. We'll be back in 5 minutes to start report.
Thank you.
Hi, Joe and Vicki. This is your nurse, Will. He will be your nurse for the next shift. Will, this is Joe and Vicky.
Hey, Joe. I actually remember you from when you were admitted last week.
Yeah, well, I remember you too.
Will is an excellent nurse. He will provide great care. Joe is here today with us awaiting a heart transplant. He's listed as a 1A. He has a history of heart failure and low blood pressure.
Heart failure, that sounds serious.
It's actually the name of his diagnosis. It's also called cardiomyopathy. We have some educational material on it, and I can bring it down as soon as we finish. We'll go over it together.
Thanks, Will.
Sure.
Today, Joe's potassium level is at 3.5.
Joe usually runs at 4. 3.5 is low for him.
That's why I feel this bad.
As soon as we get done, I'll ask your doctor about that. If he decides to order some replacement for you, we have the medication here on the floor, so it shouldn't take long to get it.
Oh, I knew I was going to like you, Will. Thanks for listening to us.
And thank you, Vicky, for providing that additional information.
You're welcome.
As far as Joe's focus assessment, he has a PICC line in his right arm, an IV running of normal saline, 50 per hour.
Everything here looks okay. Let's check his ankles for swelling. Looks to be about a +2.
I agree. So let's get the computer to review labs and medication.
Vicky, we have his potassium results. It looks like they've been trending around 4.
Great.
Oops, I forgot to chart the Lasix. I would do it right now. Joe, your next Lasix is due in 4 hours.
All the other task list items and the medications look pretty complete. I don't think I have any more questions about this.
Joe, let's set your goal for today.
I really don't know what that means.
What do you want to see happen today?
I'd like to see him get out of bed so he can maintain his strength.
I do want to get up, but I don't think I can do it by myself.
Joe, that sounds like a great goal for today, to get up out of bed. So let me go and write that on the whiteboard. Does anyone have any questions?
No, it's been great, Carol. Thank you for all the information. You've been a wonderful nurse.
Thank you. I'll see you guys tonight.
Okay, thanks.
Thank you. Boy, they were great. We're so lucky to have those two as our nurses.
Great, thank you. Prior to talking through the case study, I had asked you to write down some opportunities, and we'd like you to share those in the discussion section in the chat on your screen. What were the opportunities
in the question section, please?
In the question section, what opportunities could have better engaged a family in the case study?
Please type your answers in the questions. I did like one comment that somebody put, very observant, put that bed down because it was so high up. Listen better to them, allow time for family to ask questions, explaining the +2 on the ankles, more plain language, open-ended questions, limited discussion in common language, slow down, wash hands after touching ankles. So many opportunities with the family from the case study, they were almost an afterthought. Don't assume the patient understands what you're asking. Clearly communicate. And somebody's on the fence about whether Vicky should have said, oops, I forgot the chart.
Very good, thank you. Those are all great. Definitely in the case study with the gentleman in the ICU, the one thing that really resonated was the use of medical terms to really describe a situation that was really tense and scary for the family. Consistent messaging, and we know that plan of care change, especially between levels of care. However, it's important to really include the why when you're explaining information to families, one, in a way that they can understand, but two, really explaining why. Why was there a change? Why are we doing something different? So that the family's not left questioning, well, I was told one thing and now it's different. And in their minds, they just think, well, the team doesn't know really what's going on. They're just, things are changing from day to day, but we don't really understand. And so it's incredibly important to include why. Also treating them with dignity and respect, involving them, collaborating. In the shift report, the family was often left out. So even when the caregivers would go to the bedside for shift report, the family absolutely wasn't included. So the comment about the family really was an afterthought is definitely key there. So thank you. At this time, I will transition over to Tracy Adame. She is from Medical City, Dallas.
Thank you so much, Brennan. I am just going to take a few minutes today to talk a little bit about how some of these great strategies that have been presented can be incorporated through thoughtful, small, and intentional additions to existing patient experience strategies. Most organizations currently have a patient experience strategy that utilizes some of these principles. How can they be strengthened to be incorporated into a more health-literate healthcare organization? In addition, as these strategies are rolled out, can existing quality improvement models already in existence at the facility be utilized to maximize the effectiveness of the changes? In doing so, I looked at this process through the Plan, Do, Check, Act model, which many organizations use. In utilizing the tools in the AHRQ toolkit, they will guide you through the process of truly thinking through each of these steps and often strengthening and meeting some of the health-literate healthcare organization attributes. It is critical when rolling out these strategies to do a comprehensive assessment. In doing so, there are tools in the toolkit that can help you with a comprehensive environmental assessment to truly understand where you are prior to developing your actual implementation strategy. Decreased health literacy is a systems issue, not an individual or project-based issue, and active support of leadership is critical to all levels, but particularly in the development and implementation of the change, and in building the resources and structure to support the change for sustainability. In this process, it is very important that all stakeholders are considered and included in the planning. That does mean that we should include patients and families in developing our plans. In doing that, this will allow us to highlight the role of leadership, develop integration strategies for sustainability into our quality systems, and meet the standard of inclusion of all stakeholders in the process. Once the initial plan of what your implementation strategy is, whether that be a comprehensive patient experience strategy or simply some of the tools we talked about, such as implementation of TPAC training or implementation of whiteboards or bedside shift report, is making sure that universal precautions are used in that process to meet the needs of all patients and assume that we are always providing the easiest to understand information that can be actioned upon. Following the development of the project structure and goals, this follows a very similar strategy to other quality improvement activities. You would certainly want to go through and develop the materials that you would want to use in the process. Many tools discussed today, included in the AHRQ toolkit, can be incorporated in that process for ease of implementation. It is important that throughout this process, we continue to include all stakeholders, including patients and families, to ensure that what we are developing meets their needs. As part of this process and rollout, you would naturally develop workforce training. That training could include tools with plain language, Ask Me 3, or Teach Back based on the job role. That could include orientation and ongoing training. Many patient experience strategies in our facilities already have built-in training mechanisms. Through thoughtful incorporation of some of the tools covered today, that could be incorporated into existing efforts without having to have separate training sessions or separate initiatives. Utilization of those toolkits and having resources for staff will support them in sustainability. This process will allow for continuing to meet the HLHO attributes of workforce training, inclusion, health literacy skills, and communication through the implementation of universal precautions and clear communication tools, incorporating multimedia options when appropriate, and considering high-risk situations such as medication administration or discharge planning. Oh, one too fast. There we go. As part of this process, you will want to develop a method to analyze if you are successful. This is standard for any quality improvement activity. In our previous study, looking at health literate healthcare organizations, previously mentioned by Teresa, what we found is most organizations do collect data that could be utilized for this purpose. Developing them into a comprehensive measurement set would allow assessment and action planning both on small scale and large scale projects. Such items could be HCAHPS scores, readmission rates, patient rounding information, or the wonderful information that is found in the discharge phone calls collected by most organizations. In the analysis of that measurement set, it is critical to have a formalized structure for review that includes all stakeholders, including patients and families. Part of that process can also include the active validation of staff performance with the incorporation of checklists that Jill mentioned earlier. This can help inform the analysis and planning of future rollouts. By including these steps in your process, you will continue to support the HLHO attributes of leadership, integration, workforce training, and inclusion. Following the initial rollout of your change, you will come back and do a complete review of what you found. The next steps for incorporating that could include adding health literacy principles into your rewards and recognition programs, development of additional materials on various media platforms, and closure of backdoors for distribution of materials not approved through this process. Potential incorporation of the principles could also expand to include active training engagement of other care providers, such as physicians and vendor partners. In doing so, you will strengthen your process by following your already likely in existence Plan, Do, Check, Act model and existing patient experience and patient engagement strategies and platforms through small, thoughtful changes can meet many of the health literate healthcare organization attributes. And now I hand it back over to Brennan to follow up on the case study.
Thank you. So by the saving grace, there was one nurse that the family quickly trusted. This nurse constantly informed the family of every little thing. When the blood pressure changed, she let the family know what was happening, what they were doing about it, and why. She included the family in every plan of care update, shift change report. She kept the whiteboard updated with any pertinent changes in care and helped the family make informed decisions in care. This nurse was a true partner with the family. She understood the importance of patient-family engagement. While the other care team members were nice and took good care of the patient, this nurse stood out amongst the rest. She engaged with the family different from every other care team member in the ICU. What stands out in the family's minds is the wonderful care of one team member provided to this patient family. She will never know what a difference she made. Communication and patient-family engagement matter. Together, all of us make a better team. And while this is one case study, the same patient-family engagement principles apply for all patient interactions: discharge planning, getting a patient ready for surgery, teaching them how to care for themselves after surgery, bedside rounds, bedside shift change report, new diagnosis teaching, and the list could go on. I think what we must all be aware of is the importance of human-to-human connection. It's at the forefront of what we provide in healthcare, and we can't engage our families without having the knowledge and skill set around the impact that health literacy makes in the care that we provide. Thank you.
Hi, everybody. We've had the opportunity to listen to lots of great information. My name is Melissa Reyna, and I work at Texas Health Resources and serve as a manager of patient education. And we wanted to wrap up this presentation by talking about some take-homes. If you're like me, if you go to a wonderful conference, you come home with all these materials and cool things, but then you get back into your work situations and it's like, oh my gosh, you got to get back to the grind and everything. And so sometimes it's hard to identify some tangible things that you can do. So we'll go ahead and move on to the next slide, and we can do one more actually. And we're going to look at another poll. And what are some action steps that you can take to begin to hardwire and weave in patient education into next steps? So in the next week, what can you do within your organizations to try to move the needle forward on health literacy? Go ahead and start that poll, please.
Responses are coming in. Please vote. We'll give it another 10 seconds. And I'm going to close the poll.
Awesome. I love these results. Sometimes we don't exactly know who are others in the organization that we can work with. If you look at the backgrounds of the folks on my colleagues on this team, as well as some of the responses might guide us to think that there's a varied audience as well. My colleagues gave great health literacy resources. And the other thing is having that conversation, right, with your boss or your coworkers. Sometimes it's difficult to get, agenda time, but maybe you can influence others to do so. So we'll go ahead and go into the next time frame. And what can you do in the next month within your organization? We'll go ahead and start that poll and see what your ideas are.
The answers are coming in. We'll give it another 10 seconds to vote. And I'm going to go ahead and close the poll.
Exciting. I think we have lots of wonderful examples of some things you can do, like talk about what is plain language or those observation forms. Can we all strive to use the patient's language? You know, is there better ways to teach what we do on a regular basis? I know budgets are tight in times of COVID, and so maybe, you know, a health literacy CE is a stretch, but building parts of a health literacy, you know, development course for your coworkers is, you know, can happen in little chunks. And finally, what seems to resonate most with folks is a survey on how do folks feel. I know that we had some examples of attitude and knowledge surveys within this presentation that you could easily use those Likert scales to change up the question and see what your coworkers think. And it could be as informal as a Survey Monkey or others. And finally, we'll go into what can you do in the next 3 months? What action steps can you take? And so we'll take one more poll and understand, you know, some other things that we can do.
Good response. We'll give it 10 more seconds and then I'll close the poll. I'm going to go ahead and close the poll.
It's just like exciting because I can't see anything until the results are in. But yeah, I think definitely communicating with leadership. How do we feel? Where are we? A competency, it doesn't have to be very, very long, right? But those are easy enough to do. Those competencies can build parts of CE education for later on. And health literacy messages for patients. And I said, think of this as a service line. Think about October is Health Literacy Month. October is also Breast Cancer Awareness Month. As we are going into flu season, and how do we message the complex idea of flu and COVID? Are we doing those things in ways of, you know, that are friendly to patients and in terms that people understand? I think the other thing is looking at next year. Are there ways to look at the Health Awareness Month and then tie into each month, you know, a message that is health literate? And again, it doesn't have to be a commercial or a big billboard or anything, but just, excuse me, simple newsletters or something on a static screen, on, you know, in a waiting room. All of those are opportunities that are of low cost as we're being budget minded. Well, I want to thank everybody for your responses and the great collaboration with this team as you gave feedback and had some really awesome ideas. I'm going to turn it over to Teresa and to Patty, and they'll give you more information on how to become health literacy champions and more about the Health Literacy Collaborative. We'll also take some questions. So thank you very much.
Thank you, Melissa. So yeah, I hope that you have enjoyed today's session. As the founder and chair of this collaborative, I work for the University of North Texas Health Science Center as an assistant professor in our Lifestyle Health Sciences program, and also I am a clinical executive for Safer Care Texas, where we work to minimize preventable harm. And so this great group of collaborators today, I think, have shown you some of the milestones that we've made in understanding and bringing forward health literacy in the state of Texas, and not only in North Texas, but the state of Texas. And to say that, I want to let all of you know that we are looking towards developing an organization for health literacy across the state of Texas, getting representatives from all the corners of Texas. So if you're listening from other areas besides Dallas-Fort Worth, we welcome you. If you're interested in joining that organization, please contact me at the email you see on the screen. And if you happen to be one of the 90 hospital members of the DFW Hospital Council Foundation, you can contact Patty to join the DFW Hospital Council Collaborative. Again, happy Health Literacy Month. I maybe have time for one question, or Patty can send those to all of us to answer for you. But I'm going to let Patty take it from here.
Thank you, and thank you everybody for your presentation today. It was excellent. We have a few just comment. Thanks for the great program. Somebody already wants to get involved in the collaborative. That's wonderful. Just email me and we will get you taken care of. A suggestion from the previous was incorporate some of these ideas in compliant response to letters to the patients. Another thank you. I know one just came across, how does health literacy relate to health care?
Well, that depends on what level of care you're referring to. So if you're talking about a healthcare organization, it plays a role in everything that healthcare organization does, because as we've looked at today, every interaction you have with a patient, it should be health literate. Every procedure you do with a patient should be health literate. Every education that you do with a patient should be health literate. And then if all of those things are in place, the patient themselves can go home and take care of their health themselves. So what we do in clinical care definitely translates to what happens in the community when a patient is at home trying to stay healthy and well or get healthy and well.
Thank you. There's one other comment. This has been excellent with perfect timing for one of her projects.
Awesome. Feel free to reach out if you need resources from any of us.
Great. So with that, I again want to thank everybody that presented today. You can imagine how difficult that was to get that many people during a pandemic to put a program on, and I think they did a wonderful job. Thank you very much, ladies. At this time, you have one last chance to get our webpage there at the bottom of the slide. That is where the presentations and the recordings will live. We will also put the handouts that were on the platform today for you. And we have already opened up the evaluation. I know I said it would open tomorrow, but Lise is awesome and opened it up during this presentation. So you can go to our webpage and follow the link to the evaluation, and that is how you claim your CEs. Also, please view the posters. They are wonderful posters. Take this short quiz and get in a drawing for that autograph book from Megan Johnson. At this time, we will end our session. I thank everybody very much, and if I can ever do anything for you, please reach out to me. My email is at the bottom there. And I hope you join us next year for our 14th annual Patient Safety Summit. Everybody have a great day.